Thank you for the kind introduction. It's nice to be here. Beautiful part of the country. I was reflecting last night as I came in that I haven't been here since I drove down here from Minnesota many years ago to buy my first Arabian horse. I had met this horse in the Netherlands, and then the horse was taken to Kentucky when the owner of the stallion decided to move his family here. Rented a big jet and put all of his Arabian horses in the belly of a jet and transported them here. I saw the horse at an Arabian horse show and fell in love with it, drove down here, and lo and behold became the proud owner of a 12-year-old Arabian stallion. Brought him back to Minnesota, where he stood at stud and had 150 babies on the ground by the time we brought an end to his career 15 years later. So it was a wonderful experience. Well, I could talk about Arabian horses for an hour, but I better get on to the business at hand. As Lowell mentioned, I've had an interest in this area going back to the early 1980s. And once we saw how effective octreotide was in controlling the symptoms, and working with John Claude Royby from Switzerland, identified the presence of somatostatin receptors on these tumor cells. It was always my dream to hook an isotope onto that molecule that could kill cancer cells. That dream first came to reality when Eric Krenning decided to use high doses of the imaging agent, octreoscan, to treat tumors. The rationale for this was that when indium-111, the radioisotope that is part of octreoscan, when it decays, it gives off something called Auger electrons. That's A-U-G-E-T, not O-J. Even though that was the time that O.J. Simpson was accused of the murder of his ex-wife. So we used to joke, wasn't very funny, that these O.J. electrons were killing electrons. In point of fact, indium-111 octreotide, or octreoscan, does have significant anti-tumor effect. The two radionuclides that are circled In red on this slide are indium and yttrium. This is the agent that is part of the OctreaScan package, which preceded the use of the imaging agent you just heard about. And yttrium 90 was the second generation agent for treatment of tumors, and the current agent that's being used is lutetium. Could you move that back one slide? Lutetium, oh well, now you jumped ahead. Leave it there. So indium, to review, is the imaging agent, part of OctreaScan. Yttrium was the first therapeutic agent that was evaluated in Europe and the U.S. And currently we're using lutetium, abbreviated LU. This slide probably freaks some of you out because it reminds you of high school physics. I won't be going into a lot more detail, I promise you. So when we talk about peptide receptor radiotherapy, we're talking about an isotope such as lutetium or yttrium-90. The first one was actually indium-111, and I'll show you a slide or two that summarizes that data. Then there's a linking agent or a chelator, which allows us to hook it to a somatostatin analog or a peptide. And we've used octreotide and octreotate. And these somatostatin analogs are very short peptides made up of 8 amino acids. And the amino acids which are circled is tyrosine here, phenylalanine here, and threol here. So that's the concept of radio-labeled somatostatin analogs, an isotope, a chelator, and then the analog. The isotopes that we'll talk about include indium-111. Go back, please. Include indium-111, yttrium-90, the first generation, and lutetium-177. Yttrium-90 is primarily a beta emitter. That's the type of energy it gives off when it decays. Lutetium is both a gamma and a beta, meaning that we can image it because of the gamma rays, and the beta rays actually can harm DNA in the tumor cell. This is a summary of the peptide receptor radiotherapy experience, going back to the early days when it was first studied in Rotterdam. Includes Lowell's experience with indium-111 in New Orleans, and then includes experience in Switzerland, Denmark, Italy, and Sweden. So There was evidence early on that indium as well as yttrium-90 had objective anti-tumor activity when administered therapeutically. You can see responses listed as complete responses in a handful of patients here, but partial responses were much more common in Dr. Anthony's trial. 8% had a partial response with the therapeutic administration of indium-111, and response rates have been as high as 38%. With the report from Sweden. Now, this is the landmark trial from Europe, which prompted us to do a formal phase 2 trial here in the U.S. The Rotterdam experience was not prospective, was not randomized, but it certainly provided us with highly provocative evidence that the treatment was very, very active. This is a summary of their 6-year experience, treating over 500 patients, and there were 310 patients analyzed for response. That response was reported by Dr. Kvols in the Journal of Clinical Oncology, a journal that Dr. Anthony mentioned as the high-quality journal that most oncologists want their data reported in. Patients were treated at 8-week intervals, a total of 4 times. And I'll show you those results here. Importantly, in this trial, patients received an amino acid infusion when they were given the treatment, because we had shown in some trials that Quackenbaum, Krenning, and I did, that the amino acids would protect the kidneys. And that was important because some of the investigators who didn't use amino acid infusion ended up with patients who had to go on renal dialysis. So what were the responses in these 300 patients? For carcinoid tumors, partial responses were seen in 22% of the patients. For pancreatic neuroendocrine tumors, what used to be called islet cell carcinomas, responses were seen in 43% of the patients, and a third of the patients who had neuroendocrine tumors of unknown origin had partial responses. So overall, in these 300 patients, the response rate was very high at 29%. A number of other centers besides Rotterdam adopted this therapy, and this is a summary of those experiences, again, with over 300 patients treated. The response rate was high, and it seemed to impact on the progression-free survival. That's the duration of time from the start of treatment until the disease progressed. And you can see that the median was about 2.5 years. It was tolerated remarkably well by administering the amino acids. We totally prevented the development of serious renal toxicity. But this is the center that was not using infusion of amino acids to protect the kidneys. And you can see that they did have incidence of grade 3, grade 4 toxicity. And Milan was really bad about it. They had 24% grade 1 toxicity. Now, patients were selected based on a positive Octrea scan, and they had to have tumor uptake that was equal or greater than the uptake in the liver, or greater than or equal to uptake in the spleen or kidney. And when that was the case, there was a much more favorable response rate. You saw some images before, and this is the normal normal liver uptake, and these are tumors, and you can see uptake is greater in the tumor than in the normal liver. This is the study that my colleague John Strasberg published in the New England Journal of Medicine earlier this year. This is the landmark trial, the so-called NETTER study. I had designed and recruited a lot of my own patients to go in this trial, but then I elected to retire after 43 years in medical oncology practice. But I was thrilled to see this paper come out because it was a fruition of dreams. So John Strasberg was the lead author on this trial. And I'll try to summarize those results for you here. It was a randomized trial involving over 200 patients. And patients were randomized to either get 4 doses of lutetium octreotate or high doses of octreotide. We had shown that when patients' symptoms were progressing or their tumor was progressing on standard doses of octreotide, namely 30 milligrams per week, that we could often bring about symptomatic improvement. and cessation of tumor progression by doubling that dose to 60 milligrams of the long-acting octreotide. So that was the basis of the study. It was the experimental arm, lutetium octreotate, or Lutathera, versus high doses of octreotide. This was an international multi-center trial. Eligibility criteria are shown here. Patients had to be at least 18, have metastatic or locally advanced midgut carcinoid, had to be biopsy proven. It was grade 1 or grade 2 tumors, no grade 3. They had to have progressive disease as defined by RECIST criteria. They had to have a positive octreoscan proving that they had somatostatin receptor positive tumors. Had to have a reasonable performance status, meaning we didn't treat people that were confined to bed. And this included both functioning and non-functioning tumors. Patients were equally distributed with grade 1, grade 2 tumors, as shown here. All had positive octreoscan, as graded by the Krenning scale, grade 2 or grade 3, grade 4 uptake. Grade 4 uptake is much more intense uptake on the octreoscan than grade 2 uptake. The majority of them had elevated chromogranin, and majority had elevated 5-HIA, the metabolite of serotonin. Progression-free survival is how long the patient remains alive after they're randomized on the study. The lutetium octreotate arm, shown in green on top here. Median survival has not yet been reached, meaning the patients are continuing to do very well, whereas the patients on the control arm of high-dose octreotide had a median survival. It's as shown here of 8.4 months. So a substantial difference in progression-free survival when you compare the lutetium treated patients with high-dose octreotide patients. And this is very current. The median progression-free survival of the treatment group has still not been reached. These slides are just a couple months old. What about objective responses? About 115 patients in each arm. You can see in the sandostatin arm, there were no complete responses and 3 partial responses with an objective response rate of 3% versus 18%. That was statistically significant. And what was most impressive was the progression-free survival, and that's held up with further analysis recently. This is another look at the overall survival. Significantly better for the patients on lutetium octreotate versus the control arm. How about adverse events? Well, happily, it's been well tolerated. Nausea was seen in the lutetium arm, and that's related to the administration of amino acids, which we still have to do to protect the kidneys, but that can be somewhat dampened with powerful antiemetic drugs. There's been some thrombocytopenia, that is lowering of the platelet count, but no serious bleeding as a result of that. There's been lymphopenia that hasn't been associated with any clinical consequences. And happily, the kidney function, as reflected by laboratory tests called the creatinine clearance, has not been impacted with the use of amino acid infusion. This shows the serial creatinine clearances over almost 2 years, and kidney function has remained good. So to summarize, in this prospective randomized trial, the first one done in neuroendocrine tumor patients with lutetium octreotate, the lutetium octreotate was superior to high-dose octreotide in terms of progression-free survival and overall response rate. Interim analysis shows 26 deaths in the high-dose octreotide arm versus 14 so far in the lutetium octreotate arm. We're hoping that this drug will be approved later this year. It remains to be seen whether we'll use commercially available amino acids or a new amino acid formulation. Excuse me. And it remains to be seen whether we'll use a fixed dose versus individualized dosimetry in treating these patients in the future. This is an exciting study that should most certainly result in FDA approval, and we hope that this drug will be commercially available for nuclear medicine physicians and oncologists to use in the future. What might be coming down the pike? There are other isotopes that we could use. We did some preliminary studies with something called bismuth-213 when I was at the University of New Mexico, and that may have some promise in the future. There are other receptors that we may be able to target, such as cholecystokinin 2 receptors, CCK2, bombesin receptors, and GLP-1 receptors. There are other potential developments in the pipeline? Using antagonists to these receptors? Excuse me. So where does peptide receptor radiotherapy fit in the overall scheme? You've seen a number of exciting developments this morning, including the telotrestat studies. Currently, PRRT has only been evaluated in randomized trials in mid-gut neuroendocrine tumors. There's early phase data suggesting higher response rates in non-mid-gut neuroendocrine tumors, namely pancreatic. So further studies will need to be done in that area. We do know that somatostatin receptor positivity is a strong predictive marker. It is a treatment that should be considered a second-line therapy in patients with strong somatostatin receptor expression. It's a limited treatment course, namely one treatment every 8 weeks for a total of 4. And the studies to date indicate low toxicity and a long progression-free survival. Are there long-term risks to consider? Possibly, and that's why we'll continue to follow these patients for more than 5 years. So how does this fit into clinical practice right now? For neuroendocrine tumors not of pancreatic origin, this treatment should be considered in the face of disease progression, but other possibilities then are embolization therapy, which Dr. Anthony mentioned, everolimus, which he also mentioned, and none of these are mutually exclusive, so many patients will experience treatment with one or more of these options. It's nice to be able to have therapeutic options now. When I entered this field in the 1980s, there were very few treatment options that we had. So it's an exciting development. When it's progression of symptoms, not progression of the tumor per se, we can consider escalating the somatostatin analog. Or therapy with the new agent that's been approved, telotrestat. For pancreatic neuroendocrine tumors, we have those same options plus the potential use of chemotherapy, everolimus, sunitinib, so we have a few more options for pancreatic neuroendocrine tumors than we do for mid-gut carcinoids. Okay, I'd like to leave you with those thoughts and be happy to entertain questions during the question and answer period. Thank you.